Thank you, Chair. We're now live.
Thank you. Welcome everybody to the Health Scrutiny meeting on Tuesday, the 2nd of February. My name is Councillor McTighe and I actually chair the meeting. Thank you for everybody that's turning up, in particular our guests. If I could go to the agenda, please. Item number 1 is apologies for absence. Do we have any, Caroline?
I've not received any, thanks, Chair.
Okay, thank you. Next is any declarations of interest. I take it that's none. Item number 3. Caroline, would you like to introduce our guests for me, please?
Yes, thank you, Chair.
Thank you.
We've got, Jonathan Tapper here today, Chief Inspector Jonathan Tapper on behalf of Cleveland Police, as well as Jonathan Bowden, our Advanced Public Health Practitioner, to give a presentation in respect of Project ADDA, which Middlesbrough's recently been successful in securing some funding for. And obviously we've been doing a review in terms of opioid dependency and what's going to happen over the next 5 years and how we can make a difference on this agenda. And hopefully we'll hear from both the public health team and Cleveland Police today on what the funding will mean for Middlesbrough. Thank you, Chair.
Who would like to go first? John or Jonathan?
We're both Jonathans, just to confuse everyone. So I'm the lead for the treatment and recovery elements, and on behalf of public health. And John is the Cleveland Police lead. So I'll start and then hand over to John for the briefing on the Cleveland Police and the enforcement elements. So Project ADDA is going to see somewhere between 4.5 and 5 million in all likelihood, £1 million worth of funding come into Middlesbrough between now and the 31st of March 23. So it's just over a 2-year programme. It was initially going to be for this financial year, but between Brexit and the pandemic, it got significantly delayed. But we're very grateful for the opportunity, and it's been really sort of reinvigorating for both John and I and our colleagues to have the opportunity to think about what we can actually do in additionality for once, rather than thinking about what we need to stop doing and how to protect sort of as much capacity as possible. So given the opportunity that it affords, I'll go into some of the details around the interventions that we're proposing, but I was just going to start with a very brief overview of it, just in case anyone hasn't had a chance to fully read the briefing, or if there's any questions following that, if that's okay. So as you're all aware from the work that we've been doing together for probably the best part of the last year with yourselves in Health Scrutiny around the opiates, our drug-related deaths are at unprecedented levels locally, and ADDA, as a national initiative, its primary aim is to reduce those deaths. The 4 areas, well, it's actually 5 now. So Swansea have been added as a 5th area, but the initial 4 English areas were ourselves, Blackpool, Hastings, and Norfolk. I always go to say Norwich, but I think it's Norfolk. But anyway, we're the 4 areas, and Blackpool is obviously a very similar area in terms of the demographics to Middlesbrough. It suffers from deprivation. It's got extremely high prevalence of drug and opiate use, and there's been a number of similarities on the police side as well, including that it was a heroin and crack cocaine action area, as was Cleveland Police. So there's good synergy between the areas, and we are communicating outside of the sort of official national meetings to make sure that we're sharing best practice and making the most of this opportunity as the 4 areas. So we've also got really good relationships with both the Public Health England and Home Office colleagues, both at national and regional level, who are supporting us with Project ADDA and providing the oversight of that. So it matches the national drug strategy in terms of the sort of areas that it's looking at. So as I mentioned, treatment and recovery is led by us in public health on behalf of the council. Then there's diversion, which we're doing very much jointly with police colleagues, and then Cleveland Police are leading on the enforcement element. But we've made a commitment that we'll deliver as much as possible right across the piece in partnership, so that we can again maximise what the benefits of Project Adder. So in terms of the interventions, we've got sort of project leadership. I mean, it's called Project Adder, but the scope of what we're actually doing locally does qualify it more as a programme. So we've got a programme lead, which I'm doing on an interim basis, and there's going to be a recruitment for the next 2 years to cover 1st of April right through till the end of March 23. And then we've also got project management support via council colleagues as well. What we proposed was a mixture of staff, specialist staff resources, many of which we've lost the capacity over recent years because of funding cuts that have been obviously prevalent across the country and hit us particularly hard. So a lot of good work that we used to see, we'd actually lost through not having the specialist knowledge and capacity to deliver. So many of the roles that we're putting in are sort of replacing or building on the work that we've previously done. But we do also have a number of interventions and sort of planning processes in place that will set us up for years 2 and 3. So prevention and early intervention is something that we've lost out a little bit on, again due to the funding and capacity cuts. So we've got one of the interventions for the first few months is looking at a mini needs assessment of the local picture, gathering evidence and best practice from across the country, and almost developing a mobilisation plan for years 2 and 3, so that we can have a really good, strong, coordinated approach to prevention and early intervention, and trying to move upstream where we've actually found that we've been forced almost to focus on the most complex and at-risk clients, and that sort of really reactive end of treatment. So moving upstream and focusing more on prevention and early intervention initiatives should enable us to sort of start tackling the problem at both ends, which is obviously the ideal way to go about that. Linked to that in year 2 will be a sort of system-wide information and brief advice post, who will deliver a variety of sort of low-level interventions for adults and young people, but also encompass carers and parents of young people, looking at education and building resilience, and then some of the wider substances like cocaine, cannabis, novel psychoactive substances that used to be legal highs, and look at the pathways for linking in with our education settings and training champions who can also sort of spread this message and early interventions throughout the local system as well. We've got for year 2 again, specialist assertive outreach and engagement provision to look at the most vulnerable and high risk clients within the system, and working with those and complementary services to try and engage them more effectively, look at the really high risk transitions such as prison leavers, to try and engage them much more effectively so that they can benefit from the offer of the full system, not just sort of bounce in and out of treatment, or only really get their substitute prescriptions in terms of methadone most likely, or that, but really benefit from that wider support offer. We're also going to mirror that. So there's 2 posts to do that, and we're also going to mirror those adult posts with 2 young persons engagement posts. And again, that should impact on county lines, which I'm sure John will come on to in his element, and some of the coercion and really sort of risk-taking behaviour that can be a gateway to really serious harm for young people. as well as linking up with wider support services. Something that I've mentioned in Scrutiny a lot, and our colleague Danny Ahmed from Foundations has talked about, is our local naloxone program, whereby we've flooded the area with the injectable kits that reverse the effects of a heroin or opiate overdose, allowing time for an ambulance to attend and the right sort of clinical provision to literally save lives. So what we're trying to do is enhance that, and we're working with Foundations as the delivery partner to do that. So our colleague, Chief Inspector Scott Cowie, who's I believe has been to a previous panel, is taking a report that will hopefully get us the approval for frontline police officers to carry nasal naloxone kits. So whereas it's always been a very tricky issue to get the injectable kits utilised by the police with all the sort of risk assessments that comes with that. It's a bit more palatable for the nasal kits to be used, and that there has been precedent set with other areas in the country having sort of frontline officers carrying those. So hopefully that will get passed through, and we'll be able to provide training for all the officers who will be carrying the kits, and we'll also look at partnership with NIAS, the ambulance service, around co-location of the nasal naloxone kits, either within or adjacent to defibrillators, that can be either released when necessary or at least guidance provided as necessary. And finally, locating kits, the nasal kits, in 25 of our key overdose hotspot locations across the town to again target the most high-risk areas and make sure that there's the provision there, and potentially distributing take-home nasal kits from police custody is the other element that hopefully we can get the permission to roll out. Another very exciting one, and again linked to some of the discussions we've had, is how we've got increasing prevalence of cocaine use in the area. So that's both in terms of recreational use, which we've seen for a sort of steadily upward curve for a long time, but also more harmfully, where it's the primary substance in more and more of our drug-related deaths. And the coroner's sort of toxicology reports around that. We've seen an increase in it being one of many substances found, but worryingly more and more, it's been found to be the primary substance or a really key reason for drug-related deaths. So again, it's similar to the prevention and early intervention in that we've got people looking at what is that currently out there, a bit of a needs assessment, looking at evidence from across the world in terms of this one, because some very new and emerging evidence shows that there may be some substitute prescribing similar to methadone for heroin users that can have a positive effect on cocaine use, which hasn't previously been a sort of available route for our clinical partners. And again, a mobilisation and implementation plan for years 2 and 3 should be developed as a result of that piece of work. More staff will be transformation workers who will have one focused on coordinating sort of multi-agency pathways and picking up people who are more prevalent within primary or secondary care or known to social care, but maybe not engaging as effectively within substance misuse services. So one of the transformation workers will focus on that, and the other one will focus on the most vulnerable females, particularly sex workers, and again prison leavers, victims of domestic abuse, and any who are vulnerable through being pregnant as well. So they'll be dedicated to really improving pathways and transforming the approach for those cohorts. They'll be for year 2. Our hospital interventions and liaison team, the HILT service, is coming back to James Cook after having lost that for the best part of 2 years. Hospital colleagues have noticed a real impact through not having that service in terms of reattendances to A&E, readmissions into the hospital for people with alcohol and drugs issues. So what we've done is put in a coordinator post to work closely between the inpatient bit of the HILT service, but to really maximise the pathways to community support and try and much more effectively engage people, often through HILT, who aren't known to our community treatment services, and engage them so that the stop presenting in crisis at A&E or at the hospital. So that's another really good engagement route for drug users. And we're also exploring a similar post that TUV may fund to pick up the mental health underlying issues. Sorry, that's just my son in the background. I'll just bear with me a second. Sorry, he's just finished school and he's getting a little bit overexcited joining up with his friends. Apologies for that. So that will be a real benefit because we, again, as much as that's been traditionally focused on alcohol users, we've seen a steady increase in the harm that drugs is doing, and the volume of people who are attending James Cook. We did have plans for a lung health clinic, but as you can appreciate, with the effects of the pandemic, our specialist consultants and nurses in that regard are being kept extremely busy. So we've put that one on the back burner for the time being. And what we're going to deliver instead of that is a range of nutrition and dietary interventions to our other clients. So this includes things like Jamie's Ministry of Food classes, cooking on a budget, how to make healthy eating choices, and training around that. And it also includes some equipment for those people who need that to enable them to sort of put the training into practice at home. So that'll be delivered by some public health colleagues who have already done some work in the past with Recovery Connections and their cohort, and we've seen on a small scale some really positive benefits from that. So that'll be available on a wider scale through Project Adder funding. A really exciting one linked to the recovery, ongoing recovery, and ensuring that sort of positive behaviour change is sustainable is Jobs, Friends and Houses local approach. So again, linked to Blackpool being another adder area, they did a programme that was much more focused on the sort of prison leavers, called Jobs, Friends and Houses, which saw really positive results. And we've managed to secure Professor David Best, who is renowned within the substance misuse academic field as one of the foremost experts, and was involved heavily in the Blackpool project. He's also got really good networks internationally with similar schemes that have been operating in America and getting some really good results. So he's going to do some co-production with our local recovery community and a lot of the ambassadors from Recovery Connections to see what would work for Middlesbrough in terms of dedicated employment, training, accommodation and social interventions and pathways to really provide a good, strong platform for that long-term recovery, as I mentioned. And that can include things like training people in trades, doing up maybe RSL stock, registered social landlord stock that is hard to let, and then someone from that recovery community then benefiting from being able to then move into those premises, just as one example of what that can do. So that is a really sort of exciting one, and we've got a lot of interest by through the coup of securing Professor Best to do that with us. So that's a really exciting one. And then linked to that is a couple of capital schemes whereby we're looking at some dedicated secondary housing provision to ensure that we get the most throughput from Recovery Connections' excellent in-house rehab scheme. So usually they would have 8 flats within that project. Currently they're down to 6 because 2 of them are 2 bedrooms, and obviously with current isolation, social distancing protocols in place, they've had to go down to 1 beds. But what we see is that we're really good at engaging people and getting them on the rehab scheme. But then after they've completed their sort of first half, the initial 12 weeks, we then struggle to get them into suitable accommodation to do the second 12 weeks on an in-reach basis. So we're creating this bottleneck. So hopefully the secondary housing pathway will allow us to maximise the throughput and use the second 12 weeks to work intensively with those people to get more sustainable housing options ready for when they complete their rehab. And the second capital scheme could be one of those in terms of an Oxford House, which some of you may have heard of. It's a really good initiative, again, primarily from America, that basically sees people in recovery living together, setting the sort of ground rules within the scope of the Oxford House movement, which is similar to Alcoholics Anonymous and all of the mutual aid groups, and living by the principles and almost having a buddy system with a leader within the house, usually the person who's most strong in their recovery journey, and any sort of surplus funds that are generated by the people living in that house can go into enabling the development of further Oxford houses. So these are single sex premises, but we would look to have a male one, a female one, and potentially others, in terms of mirroring the American approach, where we've seen it explode and many houses be in a fairly short space of time, many houses be developed. So that could be one of the more sustainable longer term options for people benefiting from our rehab. And finally, in terms of the initial treatment and recovery plan, we've got building recovery in the community provision through a lead who, sorry, apologies again. So that will be for year 2 and engage a small number of people to work quite intensively with in developing local community offers, support groups, and a sort of bespoke program of support using existing assets within our community. So things like our voluntary community sector and charitable organisations who are already out there doing great work, linking them up more with people in recovery and people within the treatment and recovery system who can benefit from that. So I'm aware that I'm firing a load of information across to you, but I'll pause there and offer any questions if that's okay, Chair.
Yes, thank you very much. You've got a very lively child there.
I have, sorry about that.
Listen, the time to worry is when they sit in a corner but not saying anything. That's the time to worry. I'll open it up to questions, but I just have a couple of questions of my own, please, if you don't mind. Yes, the funding that you referred to, 4.5 to 5 million. Can you tell me how that will be divided up between ourselves and Cleveland Police? Will it be simply, you know, my idea is better than yours, can I have the money? Or has it not yet been worked out who's going to have what? My second question is, the houses you refer to, a very good idea, but is there a time limit to how long they can stay in them, you know, once they're renovated and they're being allocated them? I think it's a good idea. I'm sure Alma will agree with me that some houses in Gresham and certainly North Ormsby would benefit from being used like that. Yes, I have, like every other councillor, it's frightening to think where we are with regard to, in the country, with where we are with regard to the deaths, you know, drug-related deaths. But I'm sure every other councillor like myself has residents ringing me saying they're seeing drug dealing, witnessing in the broad daylight. You know, where they live, they can look out the window and see it happening over and over again. They're reporting it, I'm reporting it, but it's still going on. It really is still going on. I'm sure the police do everything they can with the limited resources, but councils appear to be piggy in the middle. We get residents onto us. What are you doing about it? Why aren't you doing about it? There's very little as councils we can do other than refer it all to Cleveland Police. But residents sometimes are very reluctant to report it themselves because of backlash from residents, etc. And I think, yeah, you referred to early intervention programs. Haven't we got them in place already? I mean, please don't take this wrong way, but we hear presentations like this. We've heard them over the years. Certainly I have in the 17 years I've been here. We've got money for this, money for that, we're going to do this, we're going to do that. But here we are at the top of the list with regard to drug-related deaths. I do hope with all my heart that this works, because if this doesn't work, I can't think of anything else that will, because I can't see the government or anybody continuing to give us millions of pounds if we're not going to show them that A, we've used it properly, and B, the area has benefited from it. If you'd like to come back on any of that, please, Jonathan, before I open it up to everybody else.
Sure, no problem. So the funding is split. So Public Health England are giving the funding to basically Director of Public Health Mark Adams to oversee in terms of the treatment and recovery and diversionary elements. And then the Home Office funds Cleveland Police directly for the enforcement elements. And it's largely dependent on the interventions that we propose to deliver in each year. So we had to provide a costed delivery plan of interventions, and that they get looked at and either approved or not approved by Public Health England and Home Office colleagues, and that is how the funding is determined. So that's why I was a bit vague at the beginning, saying it could be between 4 and 5 million, because we haven't submitted years 2 or 3 delivery plans yet. So we know that year 2 will be imminent, but they were the sort of outline figures we were given, and we've tried to not make it into a bun fight. As I say, we're trying to deliver it in partnership as closely as possible, so that the enforcement initiatives can be complemented by what we're doing in terms of diversion and treatment and recovery. So it should be done quite equitably, really, and we have worked well together so far, which hopefully John will echo. So we're not concerned that could be sort of detrimental in any way to the local plan. In terms of the housing provision, which I think was the second part. We're looking for a minimum of 8 beds, which would match the normal provision for the primary element within recovery connections for the secondary housing pathway, and that would give us the sort of 12 weeks to work closely with the clients and try and find them more sustainable accommodation. We realise with the poor tenancy history and the previous chaos that some of our service users have had, that it can be very, very difficult, as we're finding with them being sort of stuck in the primary for so long, that it's not always easy to keep that churn going. But just by having those 2 separate phases, we're confident that we can really increase the throughput of people. But by the same token, we would in no way force somebody to move out and put their recovery at risk, just to keep the numbers going. So that's why we've been stuck with so many people not being able to get out of the primary. But hopefully by showing that they can thrive within the sort of slightly less intensive support of the secondary process, that'll give maybe private landlords or some of our big registered social landlords the confidence that they can take people on into more permanent tenancies, and know that the support will be ongoing in terms of aftercare. And then similarly with the Oxford House, I think there's the evidence from America shows some people can stay 6 months and then feel that they have enough strength in their own recovery to move into independent accommodation. Others prefer to stay there for more like 2 years. All talking in terms of averages. Or quite often they feel strong enough to move into another house and set that up as the next recovery house and be the leader. So it sort of works quite organically rather than setting strict timescales on that. If that answers the questions about those.
Yes, it does, Jonathan. You mentioned you brought in social landlords, and I thought, immediately of people like the biggest one here is 13 Group. However, I'm sure they have some vacant properties that you could use. The sad thing is, the vacant properties that they have tend to be in areas where there's already drug activity, and that's the last place that you want people to be. I'm thinking in terms of Grove Hill. I mean, I could drive you down Grove Hill now and see quite a few properties that have been boarded up, and they will be there for quite some time. And that's the last place that you would want those people to be. So I suppose it's difficult to find the right places for where they could thrive and not be in temptation.
Yes.
Thank you.
Yeah. And then in terms of the prevention side, we have had a lot of preventative initiatives over
I said
the years.
intervention. I said intervention.
Oh, intervention.
Yeah.
Yes. So we've had a number of those all over the years, and there's been more evidence linked to the effectiveness of some of the alcohol ones than drugs. That's sort of nationally and internationally. But it really has had a detrimental impact on our ability to deliver those prevention interventions by the sort of reduced funding and associated reduced capacity. We have had to focus on the reactive treatment and much more, and we've lost things like the HILT service, and that had a very much a training and preventative element. We had a lot of there was an intervention called Have a Word that was rolled out nationally by Public Health, and we had some dedicated provision for that we lost. A number of other things that we had in reaching to GP practices and things like that, dedicated to tackling substance misuse with people who maybe wouldn't be comfortable coming into what was seen as a traditional drug service. So we had all these different elements that had to go really because of those funding issues. So we feel that having the planning and the needs assessment and then some dedicated capacity will really make a difference in being able to deliver those things going forward.
Thank you. Can I open it up to, is it David Coop? Councillor Coop? And then Councillor Rooney. Would you like to?
Yes, thanks, Chair. No, I'm very pleased this monies and things are going to be able to coordinate all this together. It's excellent news. I did note that Durham Police are the first police force in the country, I believe, to have an naloxone to be given out by officers. They're not going to inject it themselves, but they're going to give it out. I know we do that in our warden service, but I think it's important. It's something that Cleveland Police are now looking at to be able to give this out to people. So I think Durham have led the way there, but I'm sure Cleveland are not far behind. I think one of the problems is that it's been sort of lack of resources, lack of money, etc. But looking at this, you've actually got the money to be able to do it. And I'm sure, because we all know the drug problems of Middlesbrough, we all know the crime state here across the country of firearms, drug supplies. So I'm sure this will allow, as prop coordinator, because you've really thought about it, I can see from the report, as a committee, we've been looking into this for quite some time. And I know in previous committees, we've looked at naloxone in the past. So I would congratulate everybody concerned in getting this report. But one thing that people would want to see is crime taken off the streets. I think a lot of the petty crime and things like that is a lot of the problem, and people want to see results. I understand that it's a small percentage of people cause a lot of the crime. So if this will help to educate them, to keep them off the streets, I think it's excellent. But I think people will want to see results, and I'm sure you're going to deliver. Thank you, Chair.
Councillor Rooney, do you want to come in now?
Yeah, thanks, Chair. It sounds like a brilliant, really exciting project, and you know, I think we're all behind it on making sure it's a success. A couple of points. One on housing, which has already been touched on. I would want to see sensitive housing, sensitive allocations, so that people aren't put further at risk of failing as a result of just that. And given the attention that's been given to the preparation to put the groundwork in to get this up and running, how soon are results expected? Are we under any pressure to do that? And can we make it, basically? Because we don't want to start failing just because we don't miss a milestone or a target. Thanks.
Thanks. We certainly will be very sensitive. We don't want to be setting people up to fail. So in terms of placements, we're looking for expressions of interest from charities or sort of charitable incorporated companies, so that there'll be both an asset lock for the property, so that it'll continue to benefit the right client group, and also so that we're assured that they will work with us in terms of location of the capital project, the assets that will be delivered as a result. And then in terms of the longer term, that's where the partnership approach comes in, and hopefully using ADA and some of the dedicated roles to influence some of our housing partners around both reassuring them that the clients are in recovery and will continue to be supported from our services, and also the fact that they shouldn't be placing them in the middle of active drug use all around them, where we are setting them up to fail. So absolutely agree with you, and can reassure you that that's at the forefront of the planning. And then the second point that you asked for again, sorry,
Yeah, sorry, Jonathan, it was about targets, because I'm assuming we're
That's
going to
right,
have to
sorry.
report fairly quickly. And I don't want our funding really to be compromised because we might slip, for example.
Yes, yeah, good point. Thanks for that. We do have, as you can imagine, with Home Office and Public Health England, these types of schemes do have quite robust monitoring, and there are a lot of expectations, but there isn't a great deal of pressure in terms of delivering the outcomes immediately. They are realistic in that respect. But we've got, John will come on to it, but we've got dedicated analytical capacity on the police side. We've got the processes and pathways on the sort of health and the treatment side as well. Plus, we've got provision for Teesside University colleagues to provide some baseline monitoring, some baselines to be created, and then ongoing monitoring, research and evaluation with that independence outside of either Middlesbrough Council or Cleveland Police, that will feed up into the national evaluation, where they have similar arrangements with independent review and evaluation built in. So there is that whole sort of machine of monitoring and outcome reporting, but I think that they are realistic, and we said from the outset that it was important not just to have the really quantitative elements and the high level sort of performance indicators, but also what does success look like on an individual and a local level. So the heroin assisted treatment program that we've covered many times in previous panels is a good example, where some of the really highly chaotic clients and patients who are benefiting from that, a really strong outcome is just getting them to attend twice a day, 7 days a week, given how previously they've had such chaotic lifestyles. So I think that's an early indicator of success. So we'll be looking at similarly qualitative elements and case studies being produced to support what we're doing with Project ADA.
Just
Okay,
before I bring
thank
Councillor Mawson in, can I just ask you, Jonathan, with regard to social landlords, I'm sure the councillors that whose wards have a lot of social housing and will agree with me when I say that if the social landlord is here in our area, it's quite easy to deal with them with regard to issues in the houses. But there are some social landlords who live miles away and they simply ignore requests for repairs, problem tenants, blah, blah. Would it be possible to only use social landlords in our area that we could, get to with ease, sort of thing?
Yes, I think that can be part of the process. So we should have dedicated capacity within that, both the Jobs Friends houses planning and certainly the secondary housing pathway to really almost cherry pick those who we know will work effectively with us, and we can also be advocates on behalf of the clients when they become tenants of these landlords, and that ongoing aftercare support that will be provided will sort of help keep that sort of thing in check.
Okay. Can I also sorry, Councillor Martin, I'll be as quick as I can. Can I also bring in the fact that some of these people can't get employment because of the lack of education? Is that one of our intervention? Is that on our intervention programme at all to help them with their education so that there's a chance they can get employment?
Yes. So the Jobs Friends and Houses. I think it was a Canadian MP, or it comes from something that he said, either a mayor or an MP or something along those lines. He said all people need somewhere to live, someone to love, and something to do. And that's where the sort of concept of Jobs, Friends and Houses came from. So we're hoping that the jobs element will entail everything from education, training, setting people on employment pathways. We've already engaged with Job Centre Plus colleagues at the senior level, who we've worked really well with in the past, one or two of them. We've got that established relationship, and they're committed to working with us in terms of making sure that they're not unfairly sanctioned once they're seen to be engaging with the process, and that we can really support them in relevant training and education to set them on that path to employment.
I think some of them are reluctant to go to places of education because they're embarrassed about their lack of education. What I would like to see, and I don't know whether it's possible, is them, say they're given a flat or a house to live in, somebody actually going to the home and tutoring them to bring them up to a certain level whereby they have the confidence to attend a class. I know that's going to cost money, but we've got to fight for every penny. But I think that would be ideal. We have these agencies where qualified teachers go out tutoring people. I think there's a better chance of them accepting help in their own home, where they're not embarrassed about the lack of education. Thank you. Tom, can I bring you in now, please? Sorry, Councillor Moulston.
Yes, thank you, Chair. One thing first, I don't know if anybody's aware, I've just seen a news flash that 15 minutes ago, Captain Sir Tom Moore has died. A sad loss to everyone from COVID-19. On this subject,
Tom, can I just say that he was here for a purpose.
Yes.
When he did his purpose, it was time for him to go.
Yes, it's this insidious disease that's killed him. I had it last year, but just very, very mild, thank goodness. On this subject, sorry, that we're talking about, it's one great thing that's come out of this, that this isn't a problem that's going to be swept under the carpet. They're people who recognise as residents of Middlesbrough, and they're going to be treated as such. And the partnership element is essential, and I wish it every success. On a more mundane note, the nasal spray and the needle treatment, is there a sell-by date on these? And if so, is there a resource to replace them? Jonathan?
Yes, yeah, that's a good question. The injectable, all of the naloxone kits do have a sell-by date. The injectable ones do last longer than the nasal kits, but it's not sort of a really quick process. You're talking sort of six months or more at least in terms of the kits that we're buying, and we have seen both a high instance of usage of the injectable kits that we've been giving out for a longer period, but also a re-engagement of people, either to replace the kits that they've used, or once their kits are approaching the expiry date, that we're able to redistribute new kits to them. That's all part of the existing process, and will be similarly utilised for the nasal one. So yeah, that's factored in.
Thanks, Jonathan. Thanks, Chair.
Thank you.
Thank you.
And no more questions? No. Can we then go over to Jonathan number 2, please?
Yes, good afternoon, everybody, and thank you for having me. Yeah, just to echo what Jonathan said there about the reporting process, there is extensive scrutiny from the Home Office in relation to our activity and management of our budgets. And also that'll be reflected locally by me reporting directly into colleagues and senior officers at Cleveland Police. Although I've not been involved in the project for a long time, one of the real benefits is the great communication channels between the other 4 areas that are involved in the project. Certainly we'll get some scrutiny from our colleagues in other force areas and other public health areas, and also some good ideas, and we'll be able to see what's worked well in other areas and hopefully introduce them ourselves. So just to talk around the enforcement side, if I may, before I speak about our local initiatives, it's probably worth mentioning that the National Crime Agency is also involved in Project Adder, and they're looking at obviously the national perspective, but also looking to target significant supplies of drugs and also firearms nationally, but obviously that same product will be coming locally onto the streets of Middlesbrough. So there is some great work ongoing nationally by the National Crime Agency. As Jonathan mentioned there about diversion, diversion is an area where we will be working closely in partnership with our public health colleagues. And one of the schemes that's particularly exciting is we're going to look to introduce 2 full-time substance misuse key workers into our custody areas and other areas across the police estate. This will allow targeted drug testing upon arrest, which is something we haven't done for some time, and that will allow us to really understand how many of our offenders who come into the custody area are managing a drug problem, and hopefully allow us to allow those people to access engagement and break that cycle, which is critical to Project Adder between drugs and persistent crime. As somebody mentioned earlier, that there is a small proportion of people committing a lot of our crime, so hopefully that will allow us to do that. One of the other areas within the diversion heading is to target drug driving. Anecdotally, we've noticed over the last couple of years a real significant increase in drug driving arrests, and typically we're having about 4 or 5 people per day coming into the custody environment who are driving vehicles whilst under the influence of drugs. Certainly a lot more prevalent than traditional drink driving. So what we're doing at the moment, working closely with colleagues from Safer Communities to basically introduce a programme of targeting these offenders and looking at a rehabilitation scheme where they're made aware of the dangers of drug driving, introduced to support measures to prevent reoffending in the future, and hopefully working with the courts to allow engagement in such a programme to be reflected in potentially a reduction in the driving ban, etc. So that work's underway as we speak. And also, in relation to diversion, we're looking to introduce a full-time youth engagement worker who will identify young people potentially coming into the custody environment or identified as being vulnerable or exploited, and again diverting them away from crime and into the support services that Jonathan's mentioned. With reference to enforcement, traditional enforcement locally, so I'm full-time seconded to the role. and as Jonathan's mentioned, there will also be a full-time police analyst seconded to the project. Where we're at with that at the moment, so the recruitment process is complete. We've identified a suitable candidate, and we're in the process of going through the vetting and recruiting that candidate as we speak. This will allow us to identify, through the use of police data and data from colleagues, to identify real key areas for us to focus on. So to identify those real key offenders who are committing the majority of crime, identify those vulnerable young people I referred to in the past, or identify the areas that would benefit from some enhanced enforcement activity. Another area that we're looking to do is to increase the training available to our police colleagues, certainly by receiving inputs from colleagues at Recovery Connections, who are ambassadors, experts by experience. That'll help us shape our enforcement activities, and also to increase our awareness of trauma-informed practice, so to really understand what the drivers are for crime and to tackle them and address them. Apologies, I haven't got any children like Jonathan who were pleased to finish school, but I do have some noisy builders, so apologies for that. There will obviously be significant enhancement of our ability to do traditional enforcement. So that will look like execution of search warrants under the Misuse of Drugs Act, patrols of areas that we are aware are subject to increase in crime or drug misuse. And the funding that's been allocated, I know Jonathan covered this briefly, but the funding that's been allocated directly for the police to concentrate on that enforcement, it's £500,000 a year. So it is a real significant uplift in the work that's already ongoing, and it'll certainly allow colleagues to expand that work significantly. We are committed to doing a minimum number of operations per quarter, and as I've said earlier, there is a thorough reporting mechanism around what activities we've undertaken, what costs has incurred, and what the results have been. Linked to that, we certainly plan to use some of the money to expedite premises closure orders. So these are continuing with work that's already done currently, where members of the community report particular addresses where there's potentially drug dealing going on. We are looking to expedite our response to that to allow us to close these quicker and more efficiently. Obviously, that will disrupt supply of controlled drugs and identify any coerced or vulnerable people that might be cuckooed, or their addresses are being used to supply drugs. One exciting project that myself and colleagues are looking to pursue is, again through partnership with the University of Teesside, is to develop a local drug testing pathway. This will allow a very quick turnaround of testing of drugs that are recovered from our communities. And the benefits of this, there's multiple benefits. Firstly, it'll give us some real important and lifetime intelligence regarding what illicit drugs are in circulation in our local communities. And that'll be based on either police seizures or amnesties or recoveries from partner agencies. Also, critically, it'll allow us to identify any problem substances. So we have had incidents in the past where there's been a raw batch of drugs, whether it be tablets or fentanyl in heroin, which has caused a real significant problem in terms of involuntary overdoses. By identifying these drugs quickly, we can put relevant interventions in place and inform public health partners to allow these issues to be treated and tackled very quickly. And obviously, using our traditional drug testing methods, there is a significant delay. So what we typically find at the moment is, if we're reliant on our evidential drug testing process, quite often by the time we get those results, sometimes the nature of the drugs actually on the street have changed, and we're dealing with old information. I know Jonathan's already covered the request by Teesside University to do a significant research and evaluation project. That's ongoing. That will certainly identify the current measures that we've got in place, give us a running commentary on those, and certainly will give us an objective overview of the effectiveness of our response with the funding from Project Adder. And certainly one of my main focuses will be on county lines, looking at identifying significant drug gangs who are using dedicated telephone lines to supply drugs within our communities. This is often linked to the exploitation of young vulnerable people, either used to deal drugs on behalf of these gangs or to take over premises from other vulnerable people, often drug users. So that's going to be certainly a main focus of the enforcement activity. So at the moment, it is a bit of a blank page. Where we're at with the police funding at the moment, we have not received that as of yet. The applications to be made by the PCC's office. Myself and Jonathan have briefed the PCC last week. So hopefully we're aiming to get that funding as quickly as we possibly can, so we can crack on with the enforcement. I've spent my few weeks in this role briefing many of my colleagues around the organisation to make them aware of Project Adder, to get their buy-in and to identify gaps in our current enforcement activity, and to identify areas that we can target immediately as soon as the funds become available. So that's pretty much it for me. If anyone's got any questions, I'm quite happy to take them.
Right, can I just make a note, please? It's Councillor Cole. Two so far. Just before I bring you in, can I ask a couple of questions, please? Are you in a position to tell us roughly how many families are well involved into drugs in Middlesbrough, or is that you can't say?
I couldn't say that at the moment. Obviously, we are recruiting a full-time analyst, so that would be an area that the analyst could review. So no, I'm afraid I can't give you that information at the moment.
Well, can you get it for us as soon as possible, please? Is that possible?
Yeah.
Can someone get it for us, please? At some point in time.
Yeah. So
thank you.
The information required was how many families are
heavily involved into drugs, and where are they? Obviously not their address. Simply, you know, is it Grove Hill? Is it Nunthorpe? Is it North Ormsby? Is it Beechwood? Is it wherever? Please.
We can try and assist from the public health side on that and getting that sort of high level, almost a hotspot map, for want of a better description.
Thank you. Did I hear you correct where you say we're going to increase the stop and search? You were going to, excuse me, you were going to increase the stop and search. Did I hear you say that?
I didn't specifically mention stop search, but certainly our dedicated patrols will be increased, yes.
Well, that's good to hear. That's very good to hear. And can I just mention, when you say, when someone's taken into custody, are they automatically tested for drugs?
No, at the moment.
If you suspect it.
No, at this moment in time, there is no drug testing at all done in custody.
Why is that? Why is that?
Well, traditionally that was done. So for certain trigger offences, for example, acquisitive crime like theft or robbery or burglary, or clearly drug-related offences like possession of drugs, that was done. But that hasn't been done for some time now within Cleveland Police. That is obviously something that we are looking to introduce with our dedicated substance misuse key workers, who will be able to do targeted drug testing whilst in the custody environment.
And do you get an instant result?
Yes.
You do?
Yes.
Okay,
yeah.
That's fine. So can I now bring in Councillor Coop? I think you were first.
Yes, thanks, Chair. Very, very interesting what you say about that. It's like a carrot and a stick. You know, we need to help people. There's no doubt about it. But we also need to target the people who are causing the problem in the first place. And I think that your approach there, which I'm sure we have the money, you know, you need to look at the gangs, you need to look at the area, etc., etc. I'm very hopeful that will do that. But of course, with drugs, it's a different thing. With drink driving, you know the approximate times. It's, you know, early afternoon and late evening. But drug related driving could be any time. It could be early morning, late at night, afternoon, etc. So I know it's much more a problem. We've already been told in the past about heroin being an older person's drug, and I say that in advisedly, i.e. you don't get normally new addicts on that, they're onto other drugs, and as you pointed out, cocaine, etc., etc. How is the system there to spot the new drugs, these new designer drugs that come out? You have your test kits and things, you come across someone who's appears to be high-end drugs. Can you detect those sort of drugs and things to try and to understand what's going on there? And just finally, it was mentioned earlier on about, you know, the carrot, if you like, to help these people and things like that. As long as people see the results, they'll accept the help, because, as it said, most of the crime is committed by a small bunch of people. We need to help them, but we need to get them off the drugs and put them on the straight and narrow. Bit of a complicated thing, but can you just answer those questions? Thank you.
Yeah, so in terms of detecting the drugs, a couple of things I might add, if I may. Certainly the drug driving kits that we use, they are developed by a national company who are aware of different trends in drugs, new drugs that are introduced, and the range of drugs that they can detect is regularly updated in line with the legislation that's updated. So, like you say, it is a constant problem. It certainly isn't an issue. Traditionally, our drink driving campaigns have targeted festive periods, like you said, nighttime economy. What we're seeing in our data at the moment is that certainly drug driving appears to be a 24/7 phenomenon, where there are people in the community who regularly take drugs and don't associate that stigma that is out there with drink driving. So yes, I'm confident that the drug driving swipes that we use and we're looking to introduce further across Middlesbrough can detect that range of illicit drugs. But secondly, in terms of the detection of drugs, that really sort of highlights the importance of the local drug testing pathway that we're looking to introduce, because we're looking to test around about 300 samples a year of drugs, and this will really drive and inform our approach to what drugs are out there, what drugs are being used, what drugs are of favour to the local community, and what the dangers are around those drugs. So it's really important that we understand our drugs market and target that accordingly. Does that answer your question? Was there another question?
Yeah, it does. What I was saying also was, you know, you're targeting the people with these new drugs and things coming on the market. You've answered that to say that you can detect them, but it just seems a catch-up situation. Obviously, a new drug will come out, you design a drug or whatever. There's less and less heroin, which is probably easier to spot and things like that. It's just that I would worry that we could suddenly go overrun with some new drug, or we could overrun with cocaine, as has been pointed out in this thing. Can you use a lot of this money to see if you can get better intelligence led? I mean, I know across the country you've got the computer system, but you've got the people you've mentioned that are cuckooed, people like that. Some more intelligent led system to try and attack the source of the drugs. You can take out the source. You can kill the snake at its head. That obviously feeds down further down. So I'm sure it's a nationwide thing, but I think you've got to attack the source and incoming drugs. Thank you.
Chair, if I might come in. Chair, sorry, I have to leave the meeting now. Can I thank everybody for the input? Take care,
That's
everybody.
fine,
Thank
Tom.
you.
That's fine. Yeah.
Right.
Okay. Councillor Halawi wants to come in.
Thank you, Chair. Well, I'm really excited about this project and really excited to see the rollout of it. And hopefully, I'm sure actually, the success of the project. Could I make a request that we get updates in future meetings, that periodically we will find out how things are progressing? That would be good. Secondly, I'd just like to make a comment on the acronym. I think whoever devised the acronym ADDA, Addiction, Disruption, Diversion, Enforcement and Recovery. If you had to describe this project to anyone, you'd only need to remember the acronym and you'd remember what it was all about. I think that's marvellous. I see John quite likes that as well.
Yeah, but unfortunately, I can't take the credit for that, I'm afraid.
Oh.
Yeah, I agree. I think
it's a really clever, well, it's obvious when you see it, but nevertheless, it's a clever acronym to help us remember, if anybody asks us what it is, to describe it. I've been looking recently at the heroin addiction treatment centres, and I've been looking at the evidence and statistics about how successful that has been, not only in terms of benefiting individuals, but also in financial terms, saving massive amounts of up to £2 million in the treatment of people, well, preventing them from engaging in crime. So I think that particular project is marvellous, and it's an aspect of this. And the other aspect of this that I wanted to ask the question is an associated thing to the HAT treatment centres, the overdose prevention centres, which we have discussed in this panel some time ago. And I know these centres are currently illegal. I read an article about a guy in Glasgow, Peter Crikant, who's got his treatment operating out the back of a van, actually. And it's an amazingly successful method of supporting people in dealing with addiction. And we decided, I think, I'm just trying to remember collectively, I think we decided that we would launch some campaign or quest to lobby someone to try and make the case for having the overdose prevention centres be legal, so that I think, like with the heroin treatment centres, you know, we could impact significant amounts of people in a really positive way, and I think it would be really beneficial. So it was just, I think we did decide to lobby as a group, and I don't know if we did that yet or where we're at with that.
Jonathan, do you want to answer that? I take it.
Yes, well, thank you. We did discuss that early on in the sort of work stream of looking at the opiates issue, and I think it was going to be a letter to the government or to Parliament or the Home Office, and it would be really welcomed. I think we agreed to pause it initially because Danny Ahmed, the clinical partner from Foundations, was going to a UK forum in Scotland shortly after that, where he was going to sort of test the water and gauge whether that would be successful. But I think nothing really has moved on, which is quite understandable with the pandemic. But I think it would certainly benefit us to send a letter from the panel if members are agreeable to that, to see if we could garner some support to pilot a consumption room as a harm minimisation approach. As Councillor Halawi says, it's been very effective in terms of the guy in Scotland who realistically is risking arrest and prosecution.
Yeah.
So we don't want to be putting people in that position, but we know from international evidence, particularly really good evidence in Canada, that this can literally save lives, countless lives, and be a really good, equally importantly, a really good way of engaging people onto a recovery journey as well. So it is about breaking the cycle as much as the harm minimisation element of saving lives. And then going back to something that John said, potentially further support from the group along a similar line could potentially look to get support for testing some drug testing approaches, which again are currently difficult and not really supported by legislation, but do work in other areas, other countries, sorry, that again, maybe in year 2 or even year 3 of Project ADDA, we could look to pilot those as well. So any of that support would be really welcome. Thanks.
Can I come back in, Chair, please? Thank you. Really, I'm really happy to be at the forefront of such a campaign or lobby, Jonathan, because I really value the positive impact that could have on our community. And furthermore, to give it more weight, would it not be of interest for you, Rex, I'm giving you a job now, Jonathan, to ask some of the other areas that are involved in the ADDA project if they would like to join us, you know, to make our voice more impact, to give us more impact, if we would like to pilot, spearhead, and be part of a project that's not illegal, obviously, just to examine the evidence, the data, and I'm sure we get loads of positive outcomes from that. It's just that we can't find a volunteer who's willing to break the law, like Peter Crykent in Glasgow. I've been asking people, would you break the law and do this? Because it's a really good thing. I shouldn't be saying this in front of you, John Tapper, that is. But, you know, it is such an important initiative that can really have proven benefits, as you say, over in Canada. I've read the research. It's such an important project. So I'd be pleased if we could invite other areas of the country to join with us, provide a lobby, and ask if we can be a pilot, please. That's my request to the group.
Could the chair and vice chair unmute their microphone if they'd like to speak? Sorry, chair, I had to mute your microphone just whilst your home telephone was ringing. So if you could just unmute, please. Thank you.
Okay. Would anyone like to answer, Councillor Lowy, please?
Yes, we'd certainly welcome that. I think hopefully John would agree that it'll the strength in numbers, and part of the remit of Project Adder is around influencing legislation and proving the beneficial outcomes that a little bit of investment and sort of dedicated professional capacity can have on some of these areas. So that would be really welcome. I'll bring that up in one of our forthcoming meetings with the other areas, and hopefully they'll be supportive too.
Thank you. Chair, could I just finally say, I know on a political note, but I do know that we have the support of Andy MacDonald on this, and I know that it might be interesting politically to get other local MPs to join in our pursuit of piloting such a scheme. You know, there is a political angle, obviously, as well as the public health angle. Thank you.
Thank you, Alma. Have we gone as far as we possibly can with that today? No more questions, no more comments? No? Jonathan.
Sorry, it was just to bring you up to speed with a last couple of bits. So thanks for all of the ongoing interest in the opiates work stream as a whole. We've really found it beneficial to have the ongoing dialogue with yourselves, and the interest is really welcome. Clearly, Project Adder has a lot of links to not just the overt links to that agenda, but to our forthcoming integrated service model that will start from April onwards, that includes substance misuse, domestic abuse, homelessness, etc. And the additional capacity and specialist posts should really both underpin the delivery of that model, but also complement it in a lot of ways as well. What I would like to say, that I was literally just on a call prior to this meeting starting. There's an opportunity to increase our substance misuse public health grant for next financial year for us and every other local authority by approximately £400,000 to £500,000. Again, as a reaction to the record levels you may have seen in the press again today. We're starting to see the impact of the first lockdown on alcohol-related deaths. So both drug and alcohol-related deaths are at the highest levels ever on record. So hopefully we should see an increase to our grant, as I say, for substance misuse for next financial year at least, which again I will keep the group fully briefed on. Absolutely happy to provide ongoing feedback as well on Project Adder specifically, and that was it really. I've noted down the requests, and I'll continue to come back, and I'm sure John would be happy to as well. Thank you.
Councillor Cooper wants to come in.
Just to say that although we said earlier on that heroin use is going down, you mentioned opioids there, which of course we've spent a lot of time on, and there's still the misuse of prescription drugs and other opioids that are available. So it's still a very important thing, and the things that's lacking that runs in parallel with the illegal drugs, if you like, and the prescription drugs, which may or may not be got from the same source. So I think it's important that we can continue down that way, and I think it's excellent what's been done, and I look forward to some results in the future. Thank you, Chair.
Thank you, Chair. Anyone else before we say goodbye to John and Jonathan? No. Okay, well, goodbye, John and Jonathan, and thank you very much for very informative presentations, and I'm sure that we'll see you again soon. And good luck with everything. Good luck with everything. It's a hard task. It's a hard task, but I'm sure you'll do your best. Thank you.
Will.
Thank you very much.
Thanks a lot. Bye.
You're welcome to stay for the rest of the meeting, but I know that Jonathan, you've got your hands full behind the scenes there.
Absolutely.
Yeah. Bye-bye.
Thanks.
Bye.
Take care. Bye.
Thank you.
Bye. Bye.
Right, item number 4 on the agenda is the last 2 OSB meetings. And I think perhaps for the benefit of people outside who are watching this programme who may not know what the OSB meetings are, I'll just give a brief explanation. OSB stands for, what's got on my mind?
Overview and Scrutiny Board.
Thank you very much. I've got the phone call. It's quite important in my ear. Overview and Scrutiny Board. And when the mayor and his executive make an important decisions, which they do, if councillors aren't happy about it, they can they can call in the decision and ask for the Overview and Scrutiny Board to look at it, and with a view to it going back to the executive and the mayor to be looked at again. And that's what the last last one of the meetings was. So the last one was on the 27th of January. And that was a presentation by I think his title, I'm correct in saying, the Executive Director of Finance, Ian Wright. And he gave us a presentation on the proposed new budget. And during that presentation, when it finished, councillors were invited to ask questions and get answers, which they did. And that was it in a nutshell. And the OSB meeting on the 29th of January was a call-in, and it was brought by, I'm sure I'm allowed to name it, was brought by Councillor Rathmell and 1 or 2 other councillors. They weren't happy about the decision made to, if I'm just out of sure, the disposal of some land in Nunthorpe. I'm sure Caroline would correct me if I'm wrong. It was a long and protracted meeting. It was a meeting like I've never heard before. But at the end of it, we took a vote, and we decided that, yes, we would like it to go back to the mayor and his executive to look at again. And they will do that, and they will bring their result back to us, I believe, on the 9th of February. And that brings me to agenda number 4, any other business? And we haven't got any, I don't think. No. Agenda item number 6 is just to say that our next meeting is on the 16th of February. Have I missed anything out, Caroline? No. Okay, well, all I have to say is thank you for attending. Excuse me. I'm sure it's been very, very informative. Thank you for joining in with all your intelligent questions, etc. Have a pleasant evening, and we'll meet again on the 16th of Feb. Goodbye, everybody.
Thank you, Chair.
Goodbye.
Bye.
Thank you.